It is recommended that all patients with advanced colorectal cancer get RAS testing up front. It's by NCCN guideline and by ASCO guideline. The reason for that is in a couple of folds. Number one is that if you know the patient has RAS wild type and has a left-sided tumor, there's an advantage of using EGFR drug over anti-VEGF drug in a first-line setting. Therefore, if you have a patient who is left-sided tumor, RAS wild type, then you can decide and you can have a discussion with the patient in regards to using EGFR-based therapy or anti-VEGF-based therapy. And even if you don't use EGFR drug up front in RAS wild type, then you at least have a battle plan. You know what the plan is in terms of what to use in second or third line if the patient's RAS wild type. So it is very important to know the RAS status up front so that you have a battle plan in terms of how to manage the patients.
Molecular profiling is important. One of the questions is, do you wait for it? You've got a brand new patient with metastatic disease, you've sent off the molecular profile. It might take 1-2 weeks for that to come back. You've got a patient in front of you eager to start treatment. Do you have to wait? In lung cancer, remember, we wait because the molecular profile really matters and really distinguishes treatment options for patients. But in colon cancer, we've kind of been on the other side of things, is that we don't need to know right away. Well, we now have one subset of patients, left-sided colon cancer patients, where EGFR therapy, if you're RAS wild type, if you're BRAF wild type, is really very potent frontline therapy. High response rates, improved outcomes, and the like. And so in a patient with left-sided colon cancer, I think you want to know this right from the beginning because you might choose to play that sort of biologic in frontline. Now, you could decide to just go ahead and get started either without a biologic or with, say, bevacizumab and decide that you might want to change if you had that scenario. Do all left-sided colon cancers need EGFR therapy? I'm not sure that's really the case. Certainly those patients where you need a response, so big, bulky tumors, this is really a very good frontline option for patients. Left-sided, RAS wild type, BRAF wild type, you want to know RAS. There's a debate right now about in right-sided colon cancers, would you ever give an EGFR therapy even if they have RAS wild type, BRAF wild type? The frontline data says you probably shouldn't do it. And in fact, guidelines have been modified to reflect that. But what about second line and what about third line in right-sided colon cancers? And I have to say that I generally will some point along the way try it, but without a lot of enthusiasm. However, on left-sided colon cancers, my enthusiasm is high. The way I think about it is I have a face card in my hand that regardless of line of therapy, I'm going to get a response or have a very high likelihood of a response, whether that's front line, second line, or third line and later. And so knowing that allows me to play a better chess game in deciding when to use EGFR therapy as long as I know the RAS status.